Today I had the privilege of chatting with the very well-known Dr. Vonda Wright. Dr. Vonda Wright is a double board certified orthopedic surgeon and sports medicine doctor. She has treated patients from every age group. She has been very, very active in the sports community, looking after athletes, rugby players, and even ballerinas. And she has turned her attention in recent years to really getting the message out to women regarding their bone and muscle health in the peri and post-menopause period. And she's all about us not becoming frail old women who topple over and break a hip, but actually strong females who are into the next phase of our life, really killing it. Dr. Vonda is also an author of 2 incredible books, one called Fitness After 40 and another called Guide to Thrive. I'm so excited to share this conversation with you. You're absolutely going to love it. You will learn so much. Let's get into it. So, Dr. Vonda, thank you so much for joining me on All About You. We're really excited to have you and your amazing depth of knowledge on this subject. I'd love you to introduce yourself to our audience and tell us a little bit about how you ended up in this space.
Well, I'm thrilled to be here, and thank you for getting the time zones coordinated. You know, I have consulted for Australian companies, and it's really interesting to do this, actually. I'm halfway around the world from you. So anyway, thank you for having me. So, you know, across my career, and I've been practicing quite a long time, I've worn several hats. And so my critical qualifications in medicine at all are I'm a board certified orthopedic sports surgeon. I trained and received a fellowship. And so the surgical part of my life has been always very tertiary. I'm the expert's expert. People send me their hard cases, and I get to take care of the most amazing athletes. I am a multifaceted, very curious person, and so my practice has never been just in that one lane. So my research throughout my entire academic career was in musculoskeletal aging and longevity. And so I sit at a Venn diagram right now in this part of my career, probably the last 10 years of my formal surgical career, where I am involved with human performance in orthopedics. I am very interested in aging and longevity, as always have been. But in 2012, I came across data that said women make 80% of all the healthcare decisions in this country for themselves and everyone they influence. And so what struck me is that at the time, women didn't realize that. And so they were leaving their power to change the health of everyone that they influence on the table. And, you know, that struck a chord with me because my first job right out of college, and I'm going to age myself now, people are going to start calculating when I say this, but I got out of college in 1989, and my very first job, I went right back to graduate school, and my first job out of training was as a cancer nurse. And so when you're 24 years old and you are taking care of people in the fight of their lives, most of them women, at the time we were just learning how to treat breast cancer well, it leaves an indelible mark. And I came away from that experience, which we can talk more about later if you want, realizing that women are worth saving. So currently in my Venn diagram, I have the sports performance, I'm an ortho doc to elite sports teams, I'm aging and longevity, and the health of a woman. Even though it's interesting, somebody said this to me yesterday, I've always considered myself, because of orthopedics, a tertiary doctor. I take care of the hardest cases. She said to me, in today's world, it's hard to be a generalist because everyone has chosen a path. And I've never considered myself that. But what I do hold on to is I am a whole person doctor. Meaning today in my orthopedic clinic where I've just come from, I had multiple women who came in for orthopedic problems, but all of them in midlife, and all of them, we ended up having the full gamut of discussion about hormones and perimenopause and menopause. And even one of them, I was chuckling to myself, we even got down to the fact that sex is very painful for her. And in front of her husband, I told her that she had the gynecourinary syndrome of menopause and she needed vaginal estrogen. That may be I am the only orthopod that's ever said that out loud. And so that's where I'm practicing right now. And it's led to doing great stuff like talking to you in Australia.
Amazing. And so how did you become more interested and become part of this menopause of doctors who are really pushing forward and trying to get that education out there?
You know what? The menopause is not something formal until really recently. How it started, honestly, was I had known Mary Claire Haver, Dr. Mary Claire, everybody knows her now. I had known her on the internet, and we had communicated like so many of us have on the internet. And in 2020, during the heart of COVID, I did a virtual summit where I invited 20 doctors, and Dr. Kelly Casperson was one of those doctors. But the three of us had never met in person. So we were going to a swell event in New York, and it was the first time the three of us had met, and we just went for a walk together. And it's like we were sisters who'd never met before. And there were, what I have to say about those two in particular in the menopause, but nearly the whole menopause, is that we live in abundance. Like sometimes women can pit themselves against each other in a competition. There is none of that. Realizing that the need is so great and that there's enough need that we can all serve women and elevate each other. And that's always been my philosophy, is that when I make the tide rise, all boats will rise with us. And that is really the atmosphere of the menopause. So it was Kelly, it was Dr. Mary Claire, it was me. It quickly added Corinne Men and Suzanne. And then right now there's about 220 of us who are actively churning the waters every day and fighting for women, because we all believe that women are worth saving.
Absolutely. And did you have any personal experience that made you a little bit more sort of determined to get involved?
Well, I think the reason I'm involved is part professional and part personal. I think my professional involvement came first, and then I realized, oh my God, I have my own menopause, perimenopause story. So professionally, it came about because I take care of both men and women, athletes, non-athletes, who are active people. That's the common denominator. They're active people. I got so many women in my clinic with frozen shoulder. Like every other woman couldn't lift her arm or do her bra strap. So as I began down this frozen shoulder road and read the paper by Jocelyn Wittstein from Duke, who is an orthopedic colleague of mine, that showed that women on estrogen have lower incidence of frozen shoulder. And then myself and a couple of my research assistants, we wrote a paper that we just submitted, coining the nomenclature, the musculoskeletal syndrome of menopause. We're building this knowledge base. We're building this voice. And then I said to myself, oh my God, my menopause story is that at 40, I was in the best shape of my life, running marathon, training for triathlons, 19% body fat. I had just had my only biologic child, and my career was taking off. And at 47, I thought I was going to die from the brain fog. I couldn't remember the names of my instruments. I had to say, I want the thing that does this. And they're like, oh, you want your DeBakey? Or you want your literally. So there's that, and then there's the night sweats, and then there's all the things. The biggest symptom that led me scratching my head was, I'm an athlete. Why can't I get out of bed? Why am I so sore I can't get out of bed? And it was because of the arthralgia, because I was so inflamed. So all this comes full circle for me, recognizing my own menopause story out of my own work.
And so could you explain to us why we're seeing so many people with sore joints in their hands or sore feet? I keep seeing people who've got hips that are so sore that they can't lie on their side in bed, or as you talked about, these frozen shoulders. Would you be able to explain what is actually going on that we're getting all these symptoms?
Yeah, what is the science behind musculoskeletal syndrome menopause? Absolutely, I would love to. Hopefully people know by now that estrogen receptors are ubiquitous on every tissue in the body. So for the lay people listening, it's just not like proteins circulate and then somehow work. Every cell surface or in the cytoplasm of the cell, the jelly of the cell, there's these receptors that just sit waiting to do all the things they're going to stimulate doing when something sits in the basket. So when estrogen receptors are sitting there on every tissue, estrogen sits in and it does things like helps to control bone density, helps to build muscle, helps to control inflammation. But when estrogen is absent, all those amazing downstream things that estrogen would have done are undone. For instance, let's take things one at a time. So frozen shoulder and total body pain or arthralgia. Those are secondary to inflammation. Estrogen is a huge anti-inflammatory and works directly on the immune system, coordinating a giant molecule called the inflammasome. Without estrogen, our inflammation skyrockets, which leads to a lot of different diseases, but in particular in the musculoskeletal system, inflammation of the soft tissue, such as the capsule of the shoulder, leading to frozen shoulder, or total body pain, such as arthralgia. So that's inflammation. The second musculoskeletal trick of estrogen is controlling bone density. Now, I keep on my desk this femur. This is what, when 1 in 2 women will have a fragility fracture or fracture due to bad bones. When you break your hip, usually right here in the neck, that's the back, I'll do it in the front, right here, 50% of the time you will not return to pre-fall function, and 1/3 of the time you may die from the complications of having such a devastating, life-ending injury. Well, estrogen helps control the way bone is made. There are 2 major cells and a bunch of steps that make bone. The osteoclast that breaks down bone and the osteoblast. And they work in coordination to balance bone growth. But estrogen works to dampen the effect of osteoclasts. And without estrogen, osteoclasts go along the side of your bone and we become unbalanced. And more bone is resorbed than the osteoblast can possibly build. And so you're still capable of building bone after menopause, but it's out of balance. And so that's why estrogen is so critical, is to balance bone absorption. Estrogen is critical for protecting our cartilage. That's why before 50 years old, men have more arthritis than women. After 50 years old, women have a rapidly progressing arthritis picture that can lead to devastating pain and the need for total joint. I claim adipose tissue in the musculoskeletal system, and our fat shifts from the periphery to our viscera, which is smothering our guts, if you want to say it, something like that. So those are all part of the musculoskeletal syndrome of menopause with one mechanism. Estrogen is no longer there doing all the things it once did.
And so if you had someone who came to see you who is, perimenopausal or postmenopausal and they've got their frozen shoulder, would part of your treatment be to discuss giving them estrogen replacement?
I ask each and every woman that comes to see me who is midlife if they have made their estrogen decision. Now, word's gotten out that I do this kind of care, and so people are coming from all over the place, all over the world, or they know I'm going to ask them that question, or they've already made the decision. So people are looking less deer in the headlights now than they did previously. But every woman I ask, and I phrase it like that: have you made your estrogen decision, or you need to make your estrogen decision? And the way I tell them to do that is, number one, if they need the data, they need to go read Estrogen Matters by Avram Blooming and Carol Tavris. It's the book that pivoted my whole life. And I tell them that in person, and I'm just so thankful. Read the book if you need the data. Number two, menopause.org is a great U.S. website that has a big patient library. They can read the statements on what big organizations say. And Australia has a menopause society too. And then three, there are lots of the menopause that have great books. And Grown Woman Talk by Sharon Mason. Of course, Mary Claire Haver's The New Menopause. There are several others. So just pick up one of those encyclopedic books on menopause. And I said it today, so that you know what's coming. You can't avoid it. You might as well know what's coming and know what to do about it. That's how I ask women to make their menopause decision. And then there are some women whom I will prescribe for myself, but most of the time, I refer them to one of the great telemedicine platforms that there are for menopausal women or midlife women, all of whom I know their CEOs, I know their doctors. So it's not just a random recommendation. It's because I actually know the founders of the company, the doctors who serve. And so I give people several recommendations for telemedicine platforms because, as you must know, it's hard to find a doctor who has either enough education through formal education or enough education through self-education, as I do, to do that properly. And so it's easier to say things like, keep your gynecologist, have them do your pap smears, but if you need menopause care and they look at you like that's not what I do, go to a platform. Instead of fighting the battle, just go to a good platform.
Yeah, absolutely. It's the same here in Australia. I've even had someone fly from Cairns, which is right at the top of Australia, all the way down to me. So, you definitely need to try and find your specialist. So we've talked a lot. So if I go back to the frozen shoulder thing, do you have a feeling that if someone had a frozen shoulder and they took hormones versus not taking hormones, do you feel like you get resolution of your frozen shoulder quicker?
That study has not been done. In fact, there are only 2 studies in orthopedics on menopause. Neither of them are prospective studies. Though the one paper that Dr. Wittstein wrote shows that women on estrogen have less frozen shoulder, but there has not been that study. That doesn't mean that I don't recommend it every day. Because if we know that frozen shoulder is a problem of inflammation, and we know estrogen is a huge anti-inflammatory, it's pretty logical that there would be some synergy in preventing it.
Absolutely. So can I pick your brain a little bit around progesterone and testosterone in regards to joints and muscles and what they do and what they bring to the party?
Progesterone, the number one reason to take progesterone is to protect your uterus. If you take estradiol and have a uterus, you must protect it. And you do that with micronized progesterone, either 100 milligrams daily, or some people prefer to cycle it. I don't. I prefer people take 100 milligrams daily. It's suggested to take that at night because it's a sleep aid. I happen to take mine in the morning, and it doesn't seem to affect me. That is the main reason to do progesterone. It's someone today that came to my clinic had been prescribed progesterone for their anxiety. And I am not aware that that is one of the principal uses of progesterone. And that's how I relate it to her. I said, why? I questioned, why would you have been prescribed progesterone alone when what you need is estradiol and coverage by progesterone? I'm also not aware that progesterone plays a huge role in musculoskeletal tissue, although if somebody else knows a difference, I'm happy to learn, but I've not read that paper and I've read the papers. So there's that. Testosterone, on the other hand, more work needs to be done around testosterone. We know it plays a role in bone density. We know it plays a huge role in muscle. We know that women have a lot of testosterone and that levels of testosterone start dropping in the early 40s, just like estrogen. So it's not like it's not critical to us. It's just even less studied than estrogen is. And the fact that that testosterone, the only way I got it the first time was telling my OB-GYN that she kind of asked me the question as kind of an afterthought with her hand on the door, oh, how's sex? And so that was the only reason she prescribed it for me, was for libido. But the fact of the matter is testosterone is a ubiquitous hormone, just like estrogen. And so we just don't know enough about the specific, if you were to ask me, dose response or rebuilding, we don't know. But does it play a role? I'm sure it does. Most of the role we know comes from studies of men. Frankly, testosterone has been studied in men, but not so as much in women.
I think a lot of people are sometimes surprised that they've even got much testosterone. They sort of see it as a male hormone, and they're often very surprised to know that in their 20s and 30s, it was probably their most biologically active hormone. And people seem to be super surprised by that. So in terms of muscle, I know that you're someone who's really passionate around exercise and strength training. What's the interplay with testosterone there?
Well, testosterone plays a supportive role in building lean muscle mass, in helping to support bone density. I'd like everybody to be on all three, but people are specifically trying to build muscle mass. I think adding testosterone to the hormone cocktail goes a long way in supporting that goal. Again, I can't give you a dose response. This much testosterone is going to help you gain 6 pounds of muscle. I don't believe we have that data.
And in terms of muscle that we lose, we definitely lose a significant amount of muscle during the perimenopause and postmenopause. Again, do we feel like that is just a hormone deficiency thing, not driving us to build muscle like we did before?
Well, women don't really build muscle, do we? It's not on the top of everybody's mind. What are you doing today? Oh, I'm going to go build some muscle. Unless it is like it is for me, right? So we know with aging, one of the pillars of aging is sarcopenia, which is loss of lean muscle mass, or in particular type 2 muscle fibers, which are the power fibers. Those are the fibers that are going to keep us off the floor, that are going to keep us strong enough to not become frail. And we lose those preferentially with aging. And women go through that too. And then without our estrogen, which plays a role in satellite stem cell replication, in laying down muscle mass, in so many things, mitochondrial function, we just lose more. So that's why it's so critical for midlife women to make a concerted effort to give our bodies the biomechanical stimulus, which means lift heavy, that it's going to tell our bodies, oh, we need to build more muscle.
And I know that you're very passionate around sports and exercise, and you've got some books, Guide to Thrive, Fitness After 40. So tell me, if I was your patient, what would you be telling me to do? So I'm someone, I've actually been postmenopausal since I was 34. So I've obviously, that's been a long time, but what would you be telling someone to do differently than what they've maybe been doing before? Obviously, people seem to focus a lot on aerobic exercise when they're younger and they're thinking about their weight, etc. What would you want us to do moving forward?
I think the fact that people have focused on so much cardio when they're younger is societal, not scientific, right? It's just an aftermath of the aerobics era, an aftermath of the running era, right? We were cardio for years. I was cardio for years, with very little attention being paid to staying strong. So the way I approach this is to meet people where they are. It is frightening and difficult for someone who has not stepped away from the couch for any period of time, or who doesn't have physical activity as part of their daily life, whether they just never learned how, whether they've been so busy taking care of everybody else for 20 years, or whether they once were an athlete and then life takes over and they keep referring to the glory days. So even though I'm going to tell you how I want people to recompose their bodies, I recognize that nobody can jump to that. And I don't want people just to start when they're 50. I have millennial daughters. Actually, they're what comes below Gen Z? I have Gen Z daughters. I have millennial daughter. I need them to be putting down bone and muscle. And I talk about it all the time. If they do not know it, it is not because I am not preaching to them, because that is when we build our storehouses that from which we use, right? So what do I want midlife women to do now? Number one, you must eat an anti-inflammatory diet that's focused on 1 gram of protein per ideal pound a day. And it's doable. It takes some tracking. It is achievable with whole foods as well as protein supplement, high quality protein that contains adequate leucine. So that's number one. Number two, in that anti-inflammatory diet, we are not going to eat sugar. We are not eating added sugar. We are not eating white, simple carbs. It doesn't mean we're not eating carbs. We're eating fiber carbs, so you get 30 grams of protein a day. And it just is a shift. For instance, when my family wants to eat white potatoes, I am baking a sweet potato or yam, not with sugar and molasses, but just baking it because it's so fibrous if we're going to eat that kind of starch. So protein, complex carbs, absolutely no sugar, and the rest green leafy vegetables. So there's a lot more to an anti-inflammatory diet, but those are the easy things. People can only do a few things at a time. So that's number one. Number two, we have to lift heavy. So we have to provide the proper stimulus to our muscles that they'll actually build muscle fibers. If you lift a mamby-pamby pink weight 30 times and it causes no stress to your muscles, you're not going to gain any hypertrophy. You're not going to gain any power. So heavy lifting is, and I'm trying to make it simple. There's a range, but I've made it simple for my people. 4 reps, 4 sets of the compound power lifts, which is push, pull with your arms, push, pull with your legs, 4 times 4, which means you have to go pretty heavy if you can only do it 4 times. For the accessory lifts that support a compound lift, like let's take bench press. Bench press is a compound lift. The things that support it, biceps, triceps, lats, delts, rows, 8 reps times 4 sets. And that is kind of the pattern for lifting heavy. Now, we add to that, I have added foot speed and agility to that because it's one thing to be strong enough to hold yourself up. It's another thing to have the foot speed and agility not to trip and fall down, because we die of femur fractures, sometimes because our bones are so brittle they break and then we fall. But most of the time, we fall and then we break. So we need to build some fast twitch and agility muscles back. And there's simple exercises we do with that so that we can stand upright. So anti-inflammatory diet, lifting heavy plus speed and agility. And then number 3 is, what are we going to do about our heart, right? We need great cardiovascular health as well as power and strength. To build cardiovascular health, we need to do 3 hours a week of base training, which is basically brisk walking, or 45 minutes of brisk walking every day, which is not that long. Twice a week, we need to speed it up and do sprint intervals, because that is heavy enough work that then causes things like our mitochondria to replicate, all the good, yummy things we need to do. So sprinting is not like we're seeing in the Olympic trials right now. Don't worry. People get freaked out when I say sprinting. Sprinting is a heart rate measure, getting your heart rate up as high as it can go for 30 seconds, followed by complete recovery. So when I sprint for 30 seconds, I then turn the treadmill down and it takes me a couple minutes to recover. And you only do that 4 times, 30 seconds times 4. So those 3 things. Then if you want to get really advanced, you layer on VO2 max training, because that's a whole different subject. But not everybody can do these things because they've stepped away from the couch for the first time. So if you eat high protein, if you walk every day, and if you do body weight exercises, you can still lose weight. You can still recompose your body. And if you do that for a couple months until you feel comfortable, then you move up to the regimen I just talked about.
I actually had a listener ask me a question to ask you about these weighted vests that you can use for exercising. So they wanted me to know what you thought of those. And she said, what's the difference between wearing a weighted vest and then being told that carrying excess weight on your own body is bad for your joints? So I thought that was just an interesting question.
It is an interesting question. Well, yes and yes. True and true, right? So we know that heavy people have less osteoporosis than skinny, fragile people. We know that because they carry around all this extra weight. So the way to understand whether you need a weighted vest or not is to get your bone density checked, right? And if you have osteopenia and need every possible mechanism to build better bone, well, that could be an option for you. But the question is valid because we know joints bear 7 to 10 times body weight. And so when you're really heavy, that is one of the contributors to progression of arthritis. So true and true.
Amazing. Thank you so much. So we've talked a little bit about osteoporosis and osteoclasts and osteoblasts. So when do you think people should have their first DEXA scan so they know where they are with their bones in an ideal world?
I do, because I call 40-ish, whether you're 35 or 45, 40-ish, the critical decade for getting your proverbial, I could swear, but I don't know you well enough, together, right? You've got to get it together. It's time to adult. It's time to have a life insurance plan. It's time to have a will. It's time to have saved enough money so you're not starving. And it's time to start caring about your health. And so just like you need your first true physical, if you haven't gotten it before, you get your mammogram. I think you need a bone density because I have so many women showing up in my clinic in their 30s with fractures because they never laid down enough bone. Because we have had, in the United States, we've had this law called Title IX, which equalized sports participation across all educational levels. So for instance, I don't know if it exists in Australia, but if you have 50 boys playing high school sports in one school, you must have 50 girls or awful equal sports. So just to equalize play. Well, because of that, we have a huge generation of women who are athletes their whole lives. And sometimes athletes are amenorrhea, meaning they don't have periods for years because they live in a constant state of relative energy deficiency. And so they never lay down enough muscle. They never lay down enough bone. And so they arrive at 30 when they're supposed to have peak bone density, osteopenic. And so I think in this critical decade to get your proverbial shit together, you must get a DEXA scan, even if it's not paid for. Save your Starbucks money because, we can get them here. I don't know what they are in Australia. We can get them here for $99 at a gym. Some gyms have clinical DEXA scanners. And I don't buy the excuse that, insurance doesn't pay for it until you're 65. You must not need it. No, there's a difference between health prevention and disease care. At 65, you are going to be caring for disease. You're not going to be preventing disease.
And that's so interesting to me because I'm a family physician and I definitely see a lot of young female athletes and also a lot of dancers who are struggling with recurrent stress fractures and things like that. And so I know that's sort of slightly off topic, but do you think that they should be having DEXA scans?
There are many universities in the U.S. now that do DEXA scans on all incoming freshmen and as the athletes progress. Now, do they do anything with that data? That's another question. But they do it. And the chairman of orthopedics at the University of Wisconsin her entire life's research has been on bone density in female athletes. And what her work finds is that the impact sports like gymnastics have much better bone density than the non-impact sports like swimming. And that's not surprising, but she has documented that.
That's so interesting. I've got a ballerina as one of my children, so we seem to just stumble along from one injury to the next, it would seem. In terms of osteoporosis, what do we know about what HRT brings to the table? If someone already has established osteoporosis, is there any way of turning the clock back or improving that?
So I encourage, we know for sure, there's irrefutable data that estrogen can prevent osteoporosis or prevent osteoporosis. We know that. Can it reverse osteoporosis? Well, I think it should be part of the toolbox because remember, it controls the osteoclasts, as I illustrated. It controls its runaway activity. You're never going to get in front of a destructive process to try to build. The osteoblast is never going to catch up. So we have to dampen the effect of the osteoclast and rather do it with estrogen than a pharmaceutical drug. So that's number one. It must be part of the toolbox, of the roadmap. In addition to eating enough protein, knowing your vitamin K, supplementing if you need with some potassium, taking your magnesium. There's some weird supplements out there that I don't really know the data on, but boron and zinc come up sometimes. But the three you must be solid on. You must eat enough protein. Estrogen will stop the imbalance. You must lift weights. There is a study called the Lift More study that shows that even women with frank osteoporosis, when lifting in a controlled way, can do it safely, can lift heavy safely. And so I encourage all my women, even with osteoporosis, to lift heavy safely. And then walking plus or minus with your weighted vest. All of those things will add up. And then if you are still frankly osteoporotic and at risk for fracture, that's when we pull out the armamentarium of drugs. And there are very many that either maintain bone density or can rebuild bone density. And most women don't want to go on those because of the side effects. But if it's a choice between building bone back and dying of frailty, where we know if you break your hip, there's a 30% chance you're going to die, I think you need to not make that decision flippantly.
Yeah, absolutely. And in terms of supplementation, what are your thoughts on calcium supplements and vitamin D? Obviously, here in Australia, we have skin cancer and melanoma rates that are absolutely off the chart. When I first moved here from Belfast in Northern Ireland, I actually just could not believe how much skin cancer I was seeing. So we're always preaching factor 50 plus all the time in terms of SPF. And then we, of course, do see people with vitamin D deficiency. Do you have any thoughts on people taking calcium and vitamin D?
I have lots of thoughts. I would rather you get your calcium from your food and not as a supplement form, almost across the board. If you're eating a healthy, anti-inflammatory diet filled with green leafy vegetables, you're likely to get enough calcium. Although if you don't, you can always supplement 1,200, 1,800 milligrams a day, but I'd rather you get it from food. So I rarely recommend calcium supplements. Vitamin D, you need to have it measured, and the units are different in every country, but you need to have it measured. If you fall into deficit, you need to aggressively replenish it. When I first measured mine, it was barely perceptible because I'm a SPF my whole life person, except when I nearly burned my skin off when I was 16. Since then, I've been an SPF. So it was barely perceptible. And so for a while, I was taking 10,000 international units a day to catch up. And then after you catch up, you can have a maintenance dose.
So one of the things that I feel whenever I listen to you speak, which is so inspirational, is that you definitely are obviously a real specialist in your field, but you have such a generalist outlook in that you are so holistic and you've remained, not just like focused on one tiny bit of the body. How do you think we get other specialists like cardiologists and psychiatrists and also family doctors who, I think we've all become really de-skilled in hormones and menopause over the last 20 years. How do you think that we're going to convince some of our colleagues to really jump on board and learn more about this?
I do not have any expectation whatsoever that the average orthopedic surgeon is going to become as interested in this as I am. However, I do have an expectation that they're going to know enough or be aware that they're going to say, oh, part of what you're experiencing could be due to your menopause. I'm going to refer you to the right person. Because here's a great example. When we build teams of medical staff around professional athletes, and this is just an example, but it illustrates the point. Those teams are led by an orthopedic surgeon, the captain of the ship. No orthopedic surgeon who leads a team at that level that I've met believes that they can cover everything. They are not going to be the OB-GYN for the team. They are not going to be the cardiologist for the team, but they're going to have so what we do is we build a consortium of experts around our person. So we surround our people with a consortium of experts because the consortium of experts all has a knowledge enough to know when to refer or enough to connect the dots. That's the point we need to get to, because there are even OB-GYNs who are so good at the procedural part of OB-GYN, whether it's the pap smear part, whether it's the fertility part, whether it's the oncology part, that they do not know this, nor do they have the interest, because they are very good at procedures, right? So that's what I'm answering your question with. I don't expect cardiologists to become menopause specialists. I don't expect an eye doctor. But what I do expect is that every subspecialty would have at least enough knowledge to recognize, oh, this is one of the 34 symptoms of menopause. It does not require a procedure. First, it requires estrogen, and then we'll discuss whether you still have enough pain. That's the level that I would like to see us get to, because I think it's unrealistic and a pipe dream to believe that every subspecialist or every doctor who has the brain to become a specialist is going to care about the whole person. I went to a surgical subspecialty for a purpose. I'm a hip arthroscopist for a purpose. And in orthopedics, I am very niche oriented. But does that make sense?
Yeah, I agree 100%. I think we just need people to at least have their eyes open to the fact that the person with the dry eyes at the ophthalmologist, it may be related, or the person who's got the itchy ears, or the person who's got the palpitations at the cardiologist. We just want everyone to think about it. Isn't that right? And I think at this point, unfortunately, they're not.
It has to be on the differential diagnosis, right?
Talking about hips, hips come up a lot in my
Sure. The reason people get bursitis, so here's my femur again. Bursitis is when the soft tissue attached right here, your IT band, hurts. This is kind of a bony prominence. So the body has this little pillow of fluid there so that the IT band doesn't rub. That's what gets inflamed. Why does it get inflamed? Well, here's the scoop. I don't have a pelvis here. I would show you. Our pelvis is a basket, and it is meant to walk up and down the street like this. It is not meant to walk up and down the street like this, like we do when we're trying to be supermodels. That kind of gyration gives us bursitis. So how do we, without trying to walk the catwalk, get bursitis? It's because our glute medials are so weak that we can't support our own pelvis. And if the right glute med is weak, the left pelvis will drop every step, which causes tremendous friction. So all the things you said are fine. You actually don't need an MRI or an ultrasound to diagnose this. Just palpate and then test their butt strength, their glute strength. If they're weak, if they can't stand on one leg without their pelvis dropping, they must go to therapy, to your physio, to build their butt, core, and hip strength, and to work on the resulting inflammation. Because you can do all the things. You can diagnose it with millions of dollars. You can inject it 20 times, but until you get back to strengthening the core problem, which is a weak butt, core, and hips, they'll be back and back and back.
Yeah, you're right. It's just a recurrent issue that we see over and over again. So if we were to think about one thing or a couple of things that you wish women knew about their bones and their muscles and their strength, what would that message be?
Here's what I want women to know. And it comes from the fact that despite my long career, I still take trauma call. And this is what happens. And this is not meant in any way to be hyperbole. This is the reality, is that I see the future of women today, and the future is frailty unless you get in front of it. So this is what I see. I'm called to the emergency room, or I'm called to a hospital room, and a woman is laying before me, 75, 80 years old, sometimes 93. I had a 93-year-old a few months ago, and she's broken her hip. So she's laying there with her leg all crooked. She is in tremendous pain because bones are silent and painless until you break one, and then they're excruciating. So she's laying there. Often she's incontinent because what do we know? Without our estrogen, a large number of women will experience chronic incontinence. So number one reason women go to nursing homes is because they're chronically incontinent and have bladder infections. So she's broken, she's incontinent. Her heart has become so damaged from not having access to estrogen that sometimes the medical doctors like you might be on call to clear people for the OR. They're too sick for you to pass their heart. Even for a 45-minute surgery, their heart wouldn't tolerate it. And they often have a touch of dementia or are frankly diseased with Alzheimer's. That is not a one-time story. That is a everyday on-call story. And I tell you that story because bone density, incontinence, heart disease, and dementia are preventable by paying attention to your estrogen in midlife. And so the one message I want women to take away is that we have so much more control of our health and longevity than we think we do. We can never, ever live on the storehouse we built until we were 30 and expect it to last until we're 90, 2/3 of our lives. We must be continually maintaining and adding back to our bodies. So if you prefer not to have a frail future, then we must at 30, 40, 50, 60 continue to build muscle, control our loss of bone density, eat enough protein, and add energy back to the system. And the last thing I always love women to remember is that that kind of investment in your health is a daily commitment, but that you are worth the daily commitment in your own health.
Yeah, I love that. Thank you so much. You have been so amazingly generous with your knowledge. I just have one last question, I promise. If you could give your 20-something self a piece of advice, what would that piece of advice be?
I can barely remember that. I can barely remember 20. You know what it would be? I mean, I have no regrets. I sometimes, you see places, what do you regret? What would you change? Really nothing. But the one thing I would do better job of is, believe it or not, spending more time in rest and relaxation. Because I said stupid things like, I'll sleep when I die, only to find out in midlife that if you don't sleep, you will die. So
I love that. Thank you. Thank you so much. If any of our listeners would like to follow you or find out a little bit more about you or find out about your books and things, where can they find out that information?
Absolutely. So every day I post on Instagram, which is Dr. Vonda Wright. So that is the central hub for me. I only have time for one thing. I do have a YouTube channel, Dr. Vonda Wright, which has tons of videos and educational things. And then my website by the same name, Dr. Vonda Wright. But you know what's really exciting? I think all of your women should charter a plane and come to one of my retreats in Orlando. Just make it your Disney trip. Come. And we'll just treat you to all this amazing education. We'd be so happy to have you.
Oh, I'd love to come. We are big Florida fans. We are slightly crazy people who have had a Disney Vacation Club membership for the last 15 years. So we are those people who make the trek from Australia to Florida on a regular basis.
That's amazing. Well, you'll have to call me next time you're on your way.
I think you'll agree we've had some incredible guests on the podcast already, and today's was no exception. I think there is so many nuggets of information I'd love to get out there. So if you know someone who would benefit from the podcast, please share it. That way more people can learn all about themselves. Remember, this podcast is all about you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.